Our first discussion is how best to treat severe pain. My guest, Dr. Melvyn Sterling, is the co-medical director of the Palliative Care Program at St. Joseph's Hospital in Orange. Mel, thanks for coming.
Oh, it's a pleasure to be here, Larry.
Now, palliative care is a big word. What does it mean? I think most people don't know.
Well, I think the best way to think about palliative care is advanced symptom control. And what that means is for the patients who have symptoms that are really severe, very distressing, such as severe pain, shortness of breath, nausea, vomiting, severe depression, palliative medicine is the area of medicine that focuses on the management of these symptoms, the management beyond what the usual management might be.
So these are mainly inpatients, people who after surgery, or what type of patients do you see?
We see patients that are after surgery. We see patients that are admitted because their heart's not pumping correctly, their lungs are not working right, and they're very short of breath. We see patients with cancer. We see just about any kind of patient who is feeling so bad due to a particular symptom or group of symptoms that we're called in to help manage that.
So it's much more than just pain, and you have a team, right? It's not just you have other people on your team?
That's correct. Just as in other areas of medicine where things can get really quite complicated, we have nurse practitioners, social workers, we have two co-medical directors, we have a chaplain, and the chaplain is not just for religion. The chaplain is for the broader area of what we would call spiritual pain. And then we call in other subspecialists as necessary.
Wow, so you really have a big team there. I mean, that's a lot of different people doing a lot of work. And you must, I guess the hospital stays are diminished with this kind of, I mean, you can have a perfect surgery and have a patient in the hospital for weeks because they can't eat or pain, right? Have a lot of pain, right?
That's absolutely true. I'll tell you one area that's very interesting is postoperative pain in orthopedics, where if the patient's pain is not adequately controlled, they cannot work with the physical therapist.
Yeah.
So they can't get up and start to learn how to walk again after their surgery. There are similar things that occur in other areas of medicine, but that's a good model to think about.
So you make the surgeons look good.
We do our best.
And they tell you that too, I hope. So once they're in the hospital, do you follow them at home, or is that a different type of?
Well, they're at our hospital. We're fortunate to have an outpatient palliative care program. Right. So the patients who require that, yes, that's available to them.
Now, how does this differ from hospice? A lot of people probably don't know the difference, and can you explain that to me?
Yes, that's a very important question. Hospice is for people who have a terminal disease, and the Medicare program has a very specific set of criteria for that, and it means patients who have 6 months or less to live if their medical problem follows its usual course. That's hospice. Palliative care is for anybody who has symptoms that require advanced symptom control. So it's a much, much broader area of medicine.
So you will sometimes see hospice patients in the hospital initially?
We may. It is not unusual for a doctor to call us in, and after we evaluate the patient, we will say, you know, doctor, we think this patient is an appropriate candidate for hospice, or they are not, and then we would just continue to manage the patient.
Do you have any unique drugs that you use that are not available to other physicians, or is it you just know how to use them better, or how does that work?
It's mostly that we know how to use them better, but there are drugs that the American public would probably never think of as something that we would use for non-drug addicts. We use methadone because it's a terrific pain medicine. We use ketamine, which would almost never be used by other physicians. but mostly we have a great deal of experience, as you, a cardiologist, have a great deal of experience with drugs for heart disease. We have a great deal of experience using drugs for pain management and other symptom control.
You know, I've used your services, and it's a great thing for me because I don't have the expertise in that. And you can tell, you know, I can take care of hearts very well, and you can do all these great things, but then they're stuck in bed because they're nauseated or they have this pain and you can't get them to the next level. And I can spend forever playing with the different drugs, but then you say, boy, this is not working. You really need somebody like you, and it really helps so much the families and the physicians. So it's a great service. How did this evolve, though? I guess everything's become more specialized, and this is really when did you start doing this?
Well, you know, that's an interesting question, and the short answer is that no doctor can know everything. And what we've learned over the years, there's been an evolution of healthcare. And initially there was a general practitioner, and then there were specialists such as internists and cardiologists and surgeons and surgical subspecialists. Eventually, it came to the point where we realized that the management of severe symptoms really required doctors who could really focus their learning, their teaching, and their clinical expertise on dealing with those symptoms, just as the general practitioner would not try to manage a heart attack these days.
So you're board certified internist, right?
That's correct.
And then now there's another level that you have, another board certification, is that right?
That's correct. I'm also board certified in palliative medicine. And it's interesting that it was just last month that the Medicare administration recognized us as a subspecialty. The very interesting thing is that in the United Kingdom, this was recognized 15 years ago.
Oh, is that right?
Yeah.
So are there a lot of you around?
There are 2 doctors board certified in palliative medicine in Orange County.
And you're one of them. So I got 50% here in the on the show. We got 50% of you guys. That's fantastic. So the next evolution of this, I guess, is there another level that's going to happen after this, you think? Another piece of the pie that has to be put in there, or you think you're right where you want to be now?
For now, I don't see a next step, but who knows what the future will bring. I can tell you that we have made a tremendous impact on the care of patients with severe symptom management problems, and everybody is concerned about the cost of health care. It's interesting that by adding yet another team, which one might think would add expense, turns out that we decrease expense by getting people up and moving and out of the hospital more comfortably and more rapidly, and everybody's interested in that. Whether anybody can improve on that, we don't know.
Yeah, so that's fantastic. Do you, we're just about running out of time, but is this covered by Medicare and most insurance, your services in the hospital?
Yes, it is, and my parting message would be that now in American medicine, people no longer need to suffer. We have the answers to suffering.
That's fantastic. I mean, this is very informative because I knew little about it until a few years ago, and I would bet that most of the people watching this show don't know this service is available. It's fantastic. Mel, thanks so much for coming today. It was a great discussion. I learned a lot. I'm sure all our viewers did. I appreciate it very much.